Thank you very much for the introduction. So, I would like to start with a case, and I think that's very pragmatic to show you how important it is that we integrate sex and gender for research and health innovations. So, it's about Mrs. Miller. She presents eloquently to the cardiology clinic. Her main complaint is occasional chest pressure, and she reports highly variable blood pressure. She regularly exercises, but recently she experienced increased shortness of breath during activity, and she's known for high cholesterol, and she has a positive family history with a mother who had a coronary bypass surgery at 65, and a father with a heart failure who already died at 55 and had his first myocardial infarction at 40. This is a typical physician's referral for further examinations. And like often, sex-specific information is missing. And why it is the case, I would like to go back in history to explain why we are often missing such sex and gender-specific information. In 1991, Bernadine Healy, who was then the director of National Health Institute and a cardiologist, first described the so-called Yentl syndrome. Yentl, the name Yentl is coming from a short story in which Yentl is a girl who was well educated by her father, but was not allowed to study. To gain access to study, she disguised herself as a man. And Bernadine Healy used this metaphor to explain that women have to be like men to have the same access for excellent diagnosis and therapy in medicine. So, but why are men considered as prototype? It's not just in medicine, it's overall a little bit in our daily life, because the men have historically been regarded as the prototype of human beings. And so also we can see it, for example, in Berlin, traffic lights. Last year, I was in Magdeburg for the International Congress for Gender Medicine, and on my way to the station, I saw that. We have some advantages. Also with the traffic light, with women on that. But we have also other reasons that we have often less women, but also men sometimes. Consider regarding to studies in the 50s and 60s, we had thalidomide scandal. Several birth defects occurred in thousands of newborns after the drug was prescribed to pregnant women for nausea. So there are also protective reasons behind. And the female body is sometimes seen as too complex, and as we shown with this graph, very complex. Before we are unstable due to hormonal cycle changes, and also as mentioned before, for body potential effects on unborn child. That's an excellent question. Then I would like to go to the definition of sex and gender-specific medicine. It includes one hand sex, which includes biological aspects like genes, gonads, genitalia, and on the other hand, social cultural aspects, gender, like identity, role, relationship, institutions. And as the society, as I mentioned before, plays a very important role. How we live or experience our own gender. And biological sex and also social cultural gender plays an important role on our health and diseases, of how we perceive diseases, or how we use that health care system. So just also, we should also think about intersectionality. In health, we should be aware that health outcomes are shaped by overlapping factors, for example, sex and gender, ethnicity, socioeconomic status, or age. Giving an example, we could have a low-income migrant women or a high-income women. So we should keep in mind there's no average woman or man or non-binary person or whatever else. That's just a quick note, and we can tell you more later on. And I would like to go forward also with the case, and I would like to focus for this talk on cardiovascular diseases, as this is the main cause of death in men, but also in women. It's not breast cancer. And to show you how important it is to consider sex and gender. So also nowadays, this is a study from Karin Lettenmüller, my supervisors. You can see we have, if you have a look on the left side, the participant prevalence ratio, you see all the dots on some of the dots on the left sides with an underrepresentation of women. And we are talking about very common and severe diseases, for example, ischemic heart disease or stroke, where we have a lot of underrepresentation of women. And on the right side, this is analysis. You can see that this sex and gender sensitive was mentioned around almost around 100% or 98% in among demographics, but later on in a paper of results and endpoints and discussion, we don't have so many sex-specific analyses, and we should keep in mind in the demographics that regarding demographics, if we have a look on the baseline characteristics table, it's usually sex or maybe age, which is number one mentioned. So, but later on we are forgetting about this important factor. So then let's go to myocardial infarction. If you do a Google search nowadays, you also find often these pictures, yes, with men holding the chest in pain. And if you go a little bit further, maybe you find a picture, a woman scalping her husband with a collar infection. And then later on, yes, there is also a woman who has myocardial infection. And then far away, later on, we see also a picture of women with also different symptoms, maybe also more female symptoms. And it is important to know around 80% of all women and men with a myocardial infarction have this chest pain or pressure. It's not just men, but also women, the main symptom, 80%. But we should be aware that women more often have more symptoms or also have a broader variety of symptoms. For example, they're complaining about dizziness or nausea, jaw and neck pain, or shortness of breath. And this graph is from the guidelines from the European Society of Cardiology. For us physicians, this is a very important guideline. It's great that we have this, but unfortunately, it's not the main article, it's just the subject material. So it would be nice if we would be able to have a little bit more better place to put that, because it's important to know about these differences, because women take longer than men from the onset of initial medical from the initial symptoms, if they have a heart attack, to the first medical contact, because often women are also medical professionals, they are not aware about also female-specific myocardial infarction symptoms. And this is not just in other countries that this happens, it happens also in Zurich, because one of these studies was done in the Jeanne Moor. So another thing what we should consider we should also consider gender regarding bipolar and functional acute coronary syndrome, because regarding preterm acute coronary syndrome, it occurs more often in people with typical masculine characteristics compared to masculine and feminine characteristics or feminine characteristics. And if we are looking at recurrent acute coronary syndrome, if we consider sex on the left side on the right side, then men and women have equal often this recurrent of acute coronary syndrome. But if we have a look at gender, then we see a different picture. People with typical feminine characteristics have more often recurrent acute coronary syndrome. So you should keep in mind on the gender. Then I would like to talk about traditional cardiovascular risk factors. And there are a lot of sex and gender differences. For example, regarding hypertension, women have different trajectories through their lifetime regarding their blood pressure. Regarding diabetes, tobacco, and obesity, these are higher risk in women compared to men. And regarding lipids, for example, one of these lipid measurements, the LPA, changes in women after menopause. So it is recommended that the women should measure it twice in years, so before and after menopause. And regarding exercises, we have on average a reduced fitness in women, but unfortunately, men have less benefit to it. Then we should also talk about female-specific cardiovascular risk factors. For example, autoimmune diseases. We have a much more high prevalence for autoimmune diseases, and it affects the vessels, but also the heart through inflammation and immunity. Also, breast cancer, we have a higher prevalence in women, and you may know chemotherapy and radiation could also affect the heart and the cardiovascular system. Then another important topic, which we know more than 10 years ago, pregnancy complication could also affect our cardiovascular risk. And regarding acute coronary syndrome, we have, or we could have, different underlying reasons between men and women. In men, we have typically this stenosis, this occlusion of vessels, where we have, could also have, for example, Takotsubo syndrome, or a spontaneous coronary artery dissection, or vasospasm, or microvascular diseases in women, which we should also think about it. And then regarding hormones, PCOS, or polycystic ovary syndrome, endometriosis, or hormone replacement therapy, or premature menopause would also be a cardiovascular risk factor in women. And then also depression, we have a higher risk and higher prevalence among women, and this could also potentially strong association in women compared to men, which could affect the cardiovascular system. Now, I will a little go in more detail some of this topic. I will talk about hypertension. At the moment, we have no sex-specific norm values. At the moment, it's 140 to 90 our norm values, but maybe it could change because there are some studies which show that women might have a lower norm value, but let's see what happens in the next years. And we know also that women could have different trajectories of blood pressure changes. Around 7% have a high slow decline, and around 48% have a medium linear rise, and then we have also around 35% of women have a low accelerated rise of their blood pressure through lifespan, that they have a rise after the menopause. So it's important that we should measure blood pressure regularly. So, and then next topic, here regarding diabetes, we have a lot of differences. For example, psychosocial factors play a more important role to get diabetes in women compared to men. Gestational diabetes is a very important risk factors for women. Also nowadays, a lot of women are not aware. They think, okay, after pregnancy, it's done. No, this is not always the case. Around 20% of women will develop after 10 years a diabetes. And you have to think about these women with the gestational diabetes are often in their 30s, that they already may have the diabetes in their 40s. And then also other factors like PCOS, polycystic ovarian syndrome, or early menopause are risk factors for that developing diabetes. Women have more often impaired glucose tolerance, and if they have diabetes, they have more often more comorbidities. And as mentioned before, they have a higher relative risk for having cardiovascular diseases. Unfortunately, they have less guidelines directed medical treatment often, and unfortunately, they suffer more side effects compared to men. Then regarding men, diabetes is more prevalent in men. They're often, when they have this diagnosis, they are younger, are at lower BMI, and it could be also associated with overall testosterone. Now I would like to go further with adverse pregnancy outcomes, which are associated with a high risk of cardiovascular diseases later in life. I will mention these main diseases. There are also other, for example, infertility. I will mention this one because these are new or very prominent in the guidance from the European Society for Cardiology last year, and are also pretty common. And hypertensive disorders is one of these diseases which also affects 6 to 8% of all pregnant women in Switzerland, and gestational diabetes affects around 10% of all pregnant women in Switzerland, and preterm delivery with around 6%, and women with a small child with a small for gestational age, which also affects 5 to 10%. And for all these diseases, we have increased relative risk for cardiovascular disease from 1.4 around to 3. So we should keep in mind, pregnancy is a cardiovascular stress test, and which early indicate future or could indicate for future cardiovascular risk. We have now the growing prevalence of pregnancies in women with cardiovascular diseases. We have, due to high maternal age, higher prevalence of women with congenital heart diseases, which nowadays fortunately also be able to get pregnant with a higher risk. But also we have a rising prevalence of cardiovascular comorbidities, also to more people which are of this sector, which would then come up to around 60% with cardiovascular diseases. So, and we should also keep in mind, this is the leading cause of non-obstetric mortality in pregnant women. A lot of them would be preventable. What is important that we do secondary prevention, for example, in the Women's Heart Health Program, and we should not just think about the women, it's just also about the offsprings, because also the children of such women could have a higher cardiovascular risk. So, what should we do with these women? They need a follow-up after each 6 to 12 months by the primary caregiver and/or by the Women's Heart Health Program. And what should we do? To do the measure blood pressure, glucose level, lipid profile, BMI, and also check emotional stress and lifestyle. And that's also important because a lot of people, women, are not aware of that, and also physicians. If you have a look on, studies, around 50% or a little bit more of gynecologists and obstetricians are aware of that. But in other fields, for example, cardiology or general practitioners, they are not really aware of that. And we should use this window of opportunity to bring that topic to the women and also to the physicians who are involved in also midwives. Another topic which I would like to mention here is the elevated blood pressure. This is a newer definition from the 2024 guidelines, because this is defined as a systolic blood pressure of 120 to 139 millimeter mercury, and or a diastolic blood pressure of 70 to 89 mercury millimeter mercury. And you should go through this whole algorithm. And what I would like to show you, that now we have also sex-specific modifiers which are considered here, for example, gestational diabetes or preeclampsia, high blood pressure during pregnancy. And if a person has this elevated blood pressure and other cardiovascular risk factors, you already should recommend first lifestyle measurements. And if you don't reach the goals, then you should also think about medication already. And why we have this so-called elevated blood pressure is because there are some studies which show that already with this pretty, I would say, low blood pressure, that we have an increased cardiovascular diseases. Yeah. And then what is also mentioned, severe medical diseases are also a cardiovascular risk factor. So I would also like to talk about depression. We have a higher prevalence among women compared to men. I think that kind of that might be true, but it could have also other reasons, because phenotypical complaints are fatigue, arousal, sleeping disorders, for example. And these symptoms are pretty consistent with current diagnostic criteria. Further, women have different coping strategies than men. For example, they have emotional expression, strength of mind, and they are help seeking. This helps women to get in contact with a doctor and have a diagnosis and therapy. But if we have a look at men, we could have different symptoms which are not mentioned in the official criteria for getting a diagnosis of depression, for example, aggressiveness, or substance abuse. Further, in the middle, we have shame, stigmatization. It's not fulfilling the general role of a strong man to seek for help. And then what happens that we underdiagnose men and have also, which if they get seek for help, that we have already a severe depression, and in the worst case that they use suicides. So that's also important to keep in mind, this differences, also to potentially save lives, these differences. Then coming back a little bit more to cardiovascular risk calculations, we should keep in mind that some of our typical calculations which we use, that they are all based on existing data with underrepresentation of women, and that they often don't consider sex-specific risk factors. And now coming back to our case, Mrs. Miller. Now with a more detailed medical history, it becomes clear that she has also female-specific cardiovascular risk factors. She mentioned as a history of endometriosis, multiple in vitro fertilization, cycles to get pregnant, gestational diabetes, and hypertension in pregnancy, and she had a pretty early menopause for 5 years. Furthermore, she had a hormone replacement therapy since age 60 after the pregnancy episode. So, her overall cardiovascular risk is therefore higher than expected, as these factors are often unrecognized. If she had been aware of her female-specific risk factors earlier, she could also have used this window of opportunity. She got a coronary CT, heart CT, and she had a coronary heart disease. So, just to show you this case very pragmatically, how we should think or keep that in mind, that we include sex and gender-specific aspects in research and health innovations. What we need for that is health equity requires a diverse workforce, as we mentioned before, this issue. And here, this is one of the projects of my team colleagues. And you can see with the percentage of women authors per paper, you see that the percentage of women participants increase. So that's not only true for papers, it's also true for panels and boards. It's important that we really need to have diverse people in stakeholder positions. So, coming to the end, what can we do now to integrate sex and gender? On the research side, we should collect and analyze sex-separated data, ensure adequate inclusion of women any trials, of course, everybody. For example, for us pros, we should include us men. Promote diverse research team, integrate sex and gender-based analysis from study design to reporting. Report results by sex and gender, not only as an adjusted variables, but the baseline table. And regarding technology and design, use SPICE award and represented data sets, apply inclusive and intersectional design principles, test solutions across diverse user groups, and consider real-life context and gender use patterns, continuously audit algorithms for bias, and regarding healthcare practice, applies sex gender-sensitive diagnostic and treatment, increase awareness of sex-specific symptoms pattern, strengthen patient-centered and context-aware communication. I think it's always very important that we really listen to the patient, to a very individual, and not just see the sex or really understand the patient. And then also integrate mental and social factors into care and avoid one-size-fits-all in clinical decision making in the end. So, if you would like to know more about gender medicine, then check out our homepage. Or if you're interested in a women's health program, then check the QR code on the right side. And for the German-speaking part of the audience, there are also Science to Go videos, very easy explained. But I think even if you don't speak German, I think with the picture you will understand it. So thank you very much for your attention. I'm very happy to answer your questions. Thank you. Any questions?
Thanks a lot for this talk and for the examples. How would you suggest as a patient to go about and kind of enforce your physician to think about sex and gender specific factors when you approach them? Because you said some of them probably do not know about all the different factors, and you can ask a question of how would you recommend us navigating this?
First of all, it's important that also the patients are aware of that, because we we are not. It's important that we tackle to different, different people, not just physicians. We have also to inform society and so on. I think if you are aware, it's always good to have some questions with you, and even if you have questions after the consultation, just ask. That's totally fine. And of course, sometimes you have, for me, that's always with therapists. If you don't have a match, then ask somebody else. That's okay. That's okay. And yes, I think at the moment, for us that you know that, at the university we teach that. But just in, it could be more, I would say. It's depending also at which university. We will study medicine, for example, but then we have also to inform the physicians. I think we have really to make this awareness bigger in different ways. And we can do with everybody of us, but also with these videos, you can share it with your colleagues.
I have a question of integrating the information of the data, considering the condition and disease of women and men and the sex-specific, the sex-specific outcomes. I have a little bit of difficulties with understanding this information if I don't really know. In the studies, you're like summarizing if the sociodemographic variable that was conducted was sex or gender. And when you talk about sex-related, like male or female related indicators, and you still have the presentation about gender, you're talking about men and women, which is like a difference when you talk in gender studies. I know in gender medicine there is the problem that a lot of studies report sex-related results, and there are still written or discussed about gender-related results.
Absolutely, we are often a really mix of that, and I think like always, we should write it in the methods what we measure. And usually, if you talk about sex, it's the information patient, and then that should match. And also, if you measure gender, then you have to tell how did you measure it. For example, I check the social economic status, or if you're working. For example, of gender is super difficult to measure. There is, as I know, not a very good standard.
Another question from the audience, maybe online.
I don't see something, but I'm thinking,
Okay, sorry.
Thank you so much. I have a question regarding AI, because it said that AI is better in diagnosing right now than even doctors. I saw a study, I don't know whether it's true, but in the case that it should be true, then we have all the data for males, because we don't have the studies done for females. So what is your standpoint?
I think there are different studies, but what I know overall, AI is not really depending for what diagnosis, but it's not really better than physicians, and also what you mentioned. It's based mostly on often with data, so we should keep that in mind. Or, for example, if you would like to check if a woman have a chest pain, say ChatGPT, for example, I have chest pain, I'm a woman, it could more refer to you to go to the psychiatrist, because it's more psychosomatic in women. But we should really be careful with all these AI tools, and we need more studies. Yeah.
one last question. But I might have a question. What do you think? Like who should, like who doesn't know enough about general medicine? Is it doctors or is it patients or is it first makers? And who should know the most about it? Short answer, everybody. No, I think it's really depending. I think at the moment the problem is it's not mandatory often that we have to know about this. In a kind of for medical students, we have a lengthy catalog. It's written there, and they should do that, but it's not implemented in all medical schools, for example. And then we have the problem that the workforce, they didn't learn about it because it's new. And then it's really up to the societies if they are interested in general medicine or not, if they invite somebody for their congress to talk about general medicine, and if not, they don't know about it. So, oh, maybe, yeah, read an article, but you can always decide, oh, no, is it interesting or not? So it's not mandatory. Thank you. There's one more question.
Yeah, I think I have a question.
Yes.
Thank you so much. I am wondering, like, how do you handle doctor to doctor facilitation? Because if you are a doctor in a specialized setting and you want to get more information about the patient and intersectional information about the patient when the patient themselves is not aware, like how do you get the information from other facilitators and how is this working? Like, is there a network? And
You usually have to write reports to other doctors, sometimes not. Then you have just to call the doctor or write an email. And then it's always, again, depending on what you write. For example, I wrote also sex and gender specific information, and sometimes a little bit more information because I hope that they will consider it. And then you don't know what will happen in the end. Yeah.
Thank you so much.